imaging, what you do. So let's move on to the next topic here, which we are going to talk about on neuroimaging. On this, though, I'm not going to show you too much of imaging here. I'm going to concentrate on how I do the MR imaging. I'm not sure how many of you are involved in MR brain imaging. So try and listen. This is what the current imaging status for brain is. This goes away from a trauma imaging. Very rarely we do MR for trauma. I mean, there are one or two indications which we do. Certainly trauma, when we're talking about diffuse axonal injury, is one indication that comes to my mind. Post CT, we do MRI just to prove the point. But generally here I'm talking about your routine imaging, neuroimaging on a day-to-day basis. Okay, so let's start. So what I have done this is I've tried to, rather than just give you the imaging patterns, I've just tried to put it all together from a symptom point of view. I mean, how does a patient present? Like a patient presents with headache, blurred vision. What do I do? You know, things like that. I worked it out actually. Yes, so I've given you obvious sequences like a standard brain, a sequence that you go for. You know, if you're not sure which one to go for a standard. This is where it's a common sequence which is done day in and day out in my department. Very simple. In a standard imaging, your T2 is your your box standard imaging, where you tend to see a lot of pathologies, edema, etc. So put that in. I've given most of the imaging over there on the right. If you want to write it down, you can write it down, or I can share this with you later, whichever way. Flare, because of its fluid attenuation of the CSF, it tends to show up the pathology much more hyperintense, so much easier to see. So I tend to keep these imaging to a very minimum when this is like a standard screening image. So I don't really go into it, but I look at the clinical history and I might add up one or two sequences like diffusions and SWI, but generally I limit it to the top 4 sequences. So an imaging box of sequence you can go to at any time, and most of the pathologies you will try and identify with this sequence. Okay, so we move on to the next one. Very important. This is extremely important. Stroke. Stroke is significantly increasing across the world, and we are seeing much and much more of younger patients involved with stroke. And second thing, management of stroke has significantly differed. From doing nothing to thrombolysis, now we are doing direct thromboembolectomy, i.e. going through the carotid vessel straight into the cerebral arteries and plucking out the thrombus, so that we reperfuse the brain as fast as possible, similar to heart attacks, stroke attacks. So in this sequence, I've highlighted you a number of things. Diffusion is your key because it tells you the age of the stroke. In an acute stroke, okay, there are some other sequences which also I do to see whether the brain is viable or not, but with an acute stroke, your brain is viable. It's for the vascular interventionist to go straight in and try and take the thrombus out. Here is an example here on the left side. Hyperintense B signal image, diffusion scan. We have a corresponding ADC, hypointensity, diffusion restriction. We have a TOF image of the cerebral angiogram, occlusion of the M2 segment of the MCA. Simple. Interventionist goes right into the MCA, plucks the thrombus out, and works out to reperfuse the brain. So the key image here is your diffusion image, and this is a very, very important pathology that we all encounter pretty much on a day-to-day basis. If there is a question of hemorrhage in the clinical presentation that you'd have to rule out, stroke also has got where you have to rule out hemorrhage, and there are a number of indication that would include that. When you're talking about that, always include a susceptibility weighted sequences. That is very important, where you have blooming artifacts that you see here, tiny micro hemorrhages on the cortical gray white matter interfaces. Very important. This is very important. This is a patient with amyloidosis. So susceptibility imaging is a key image on when you're talking about hemorrhage in a brain. Demyelinating disorders, much more common in the Western population, but we are starting to see these pathologies even in our continent. So the sequence here that is key is flare sequences. Obviously, you could have a coronal or a sagittal. My favorite is a sagittal flare. Because of the hyper intensity that you see around the pericallosal and periventricular region. These are like small fingers standing out. I mean, it's got a terminology called Dawson's finger, but flare sequences is your key in demyelination. You can go on to do extra sequences like diffusion and contrast just to show the activity of these plaques, demyelinated plaques, just to stage the disease as active or chronic, which we are doing now. But your standard sequences, your important key sequences of flare sequence. Of those coronal and sagittals, I kind of favor a sagittal one. If you're talking about dissection, vascular involvement, obviously everybody is comfortable with the time of flight sequences, either of the extracranial or the intracranial vessels here. Very simple sequence, quick to obtain, beautiful images. Here you have the right vertebral artery. Here you can see a linear hypointensity within it. So a dissection within the right vertebral artery, the cause for the posterior circulation stroke in this patient. Simple images, a tough MR angiogram, quick and easy to do. So the next one, sinus thrombosis, again, getting much more commoner, younger patients, women who are on pills. We seem to see a lot of these things in them. So it's more and more routine. If you have a question of that in the clinical form, try and get a similar MRV image. A non-contrast is more than enough. Here we have thrombus of the left transverse and the sigmoid vein with multiple collaterals here. And you can add up sequences depending on a thrombus. Venous thrombosis can cause an infarction, so you can add a DW sequence, and it can cause hemorrhage within that infarction. So you can use a SWI. So we can play around with these things, but predominantly a venogram, MRV, simple enough to identify a thrombus. Epilepsy, very important. This is a very important topic. Younger patients that we see, and we are able to identify the cause of this epilepsy, and the neurosurgeons are able to work around this as well. So we are moved away just purely from anti-epileptic medications. We would like to identify the cause as much as possible if there is an opportunity, so that we can work on the treatment. So what is important here really is to look at the hippocampal regions. The hippocampal regions lie in the medial temporal lobe. And what is the sequence that I would want is I would want a coronal flare sequences. That is your key sequences. You could do a T1 and a T2. I would prefer a T2 coronal flare. That's my key sequences, because as you see here, that's your right hippocampus below the temporal horn. This is the left temporal horn hippocampus. There is atrophy and there is edema, hyperintense signal. Edema is hyperintense on T2 rather than T1. That's why I prefer a T2 sequences. So you could get an atrophy of the hippocampus or hyperintense signal as well. So hippocampus is where you have to look at, and T2 flare, coronals, you can do axials as well. Coronals shows it beautifully. Is your key sequences. So T2 flare is your key sequence for an epilepsy, because you would want to image the hippocampus. Once we identify the pathology, the neurosurgeon is able to go and operate on these things. So imagine if we can get somebody rid of epilepsy. That's what we are aiming to do. That. So epilepsy screening is also very important. Not sure we do a lot of dementia scanning back in Africa, but we do a lot of this in the Western world. Single digit numbers 2, 3, 4 coming around every day. Try and identify what is the cause of dementia. And again, here, the medial temporal lobe, the hippocampal regions are all the important areas to try and give us a guide about different types of the dementias, Alzheimer's, vasculars, etc. And in this one, the sequences is on a T1 coronal, a volumetric sequence to give me the volume of the hippocampus and the medial temporal lobe. So that's where my, in this, I don't really need a T2 apart from to look at an ischemic pathology in the brain where you do a T2 axial. Here on the dementia, the key image here is a T1 coronal, looking at the hippocampus and the medial temporal lobe. So epilepsy or dementia are fairly closer by actually as such. And here it's a volumetric sequence that I would want just so that I can give a graded volume of the hippocampal region. The next few slides should be used to pituitary imaging, very common. Here I would like pituitary, the key image is a T1 image, either a coronal or a sagittal, T1 and a pre and a post contrast to look for macro adenomas. T1s are very key because a pre-contrast T1 gives me the position of the posterior pituitary because it can be ectopic, can move away, and it can be positioned elsewhere, and also identifying stalk lesions like a hyper dense cyst, like a Rathke cyst, just a pure hyperintense signal on T1, and pre and post contrast enhancement about macroadenoma or a supracellular region. So T1 is your key image here. You can get it on a coronal or a sagittal, doesn't mind actually. In fact, I do both of it, but T1 pre and post is your key image in a pituitary. So when you're trying to combine brain and orbits, people have asked me, how do I do sequences for both together? Orbital sequences, I'd really, when you're kind of combining two things, I would just kind of get a coronal stir. I mean, a fat suppressed stir basically shows the optic nerve and the CSF around the optic nerve. So I can look for any meningeal pathology, glial pathologies, etc. And also gives me a clear idea about the extraocular muscles. Just a coronal stir. If you're looking at a brain and an orbit combining features on top of all your standard brain imaging, I would just kind of get a coronal stir or a T2 fat suppressed coronal. So this gives a symmetrical view of the eye. So if you're moving purely to orbits, just purely on orbits, it's your T1 coronals and axials, fat suppressed, beautiful, when you do that, you see the globe, the enhancement of the extraocular vessels, the optic nerves going in right up to the cavernous sinus. So you get a beautiful view of the globe, the retroocular pathologies. You tend to see everything beautifully on a fat suppressed T1. Obviously, you can use a coronal and axial here, pre and a post cat imaging for orbits. Okay, so last but not the least, I would finish this with again trigeminal neuralgia. This is a common component that we get people presenting with pain on one side of the face. The trigeminal nerve, if you look at the anatomy, has got 3 branches which supplies the face, and any one of them can be involved to result in a facial pain. So we get asked to image the trigeminal nerve from its origin all the way down to the face to see if we can identify a pathology that can be corrected. So what is the sequence in brain? It arises from the posterior fossa. So we use a high resolution T2, something that you use for an IAM or a CP angle, similar sequence. Here we have the right trigeminal nerve going towards the Meckel's cave. The left, you can see it is pushed by another linear structure, which is a vascular structure pushing it out, resulting in left hemifacial pain on this patient. So important pathology to diagnose. So the surgeon goes in and puts a mesh between these two structures, keeps the vessel from touching on the nerve. Simple. So it is very important. We do see this a lot coming up recently. So something for you to remember. So this your sequence, key sequence here is a high resolution T2, similar to what you do for a CP angle under an IAM sequence. So I think with this, I'm finishing off with the neuro protocols. I think I have covered as much as possible that I see in my day-to-day practice in my department. So if there is anything more that I have not covered, or you like to share your thoughts on this, as usual, please keep us posted on the chat box on the right.